Hi friends, in this case I had to perform a challenging Rhexis rescue in a patient who was bound to have a toric intraocular lens implantation. Let's see how the case went. This was a grade 1 nuclear sclerotic cataract. Patient had to receive a toric lens. I'm creating the clear corneal incision at the posterior limbal part, and then after entering the anterior chamber, I make a controlled opening on the anterior capsule, as is my practice now. Then, filling the chamber with adequate viscoelastic to tampen out the anterior capsule, I'm going in with the Utrata forceps, creating a small scratch and then starting the capsular Rhexis. So as I performed the initial sweep of the Rhexis under the subincisional area, I noticed that there was an abnormal fold which I thought was the tearing edge. But it so happened that this was just a fold of the capsule and the tearing edge was placed closer to the zonules. Once I realized that, I filled in more viscoelastic, and again I went in very carefully with the Utrata forceps. Very difficult to grasp the tearing edge in the subincisional area. Again I have this abnormal fold that gave me a false sense of guidance that the tearing edge was coming inwards, but the truth is this is just a fold of capsule. The tearing edge was still very much peripherally located. Now once this happens, you have to try to engage the tearing edge from a point diagonally opposite. This is the tearing edge very close to the zonules, or probably even enmeshed in the zonules. I had to rescue this Rhexis. So I create a small clear corneal stab incision with my 15-degree side port blade. This is exactly opposite the Rhexis runoff, which was subincisional. Fill the chamber with adequate viscoelastic, and then I'm going to use the micro Utrata forceps in order to try to retrieve the Rhexis. This forceps in itself is difficult to handle because the point at which you create the action with the finger and thumb is far away from the business end of the tip. And in this case, I had to actually use my left hand, which made it more challenging. As I grasp the tearing edge close to its tear-off point and I pull it inwards, a tuft of zonules also gets disinserted and comes inwards, after which I let go of the flap and then re-grasp it in order to minimize the zonular damage. I turned this flap inwards into the safe zone. And once I retrieved the Rhexis in this way, I was then able to complete the remainder part of the capsular Rhexis. So this Rhexis tear had gone to the periphery and I was able to pull it inwards using the Little's maneuver. And the important point is always try to grasp the capsule from a point diametrically opposite, hold the tearing edge and yank it inwards in order to turn the Rhexis into a safe zone. Thank you for your attention.